Okay, we're going to go ahead and get started. So welcome everybody to this breakout session about swing bed patient experience. So the learning objectives for this session, upon conclusion of this session, you should be able to identify specific measures to capture patient experience, create a swing bed patient survey to enhance the overall program, determine patient needs and improvement opportunities to enhance care transitions, and identify pros and cons of the pilot project using tablet versus paper surveys. With that, I'll go ahead and introduce our speakers. We have Angie Charlotte from Illinois. Angie is a registered nurse with over 27 years in the healthcare industry. She holds a bachelor's in nursing, a master's in healthcare administration, and a doctorate in business administration. Her passion and focus revolve around healthcare leadership and sustaining rural health. She holds certificates in CPHQ, Lean, and Six Sigma Black Belt, as well as the Compliance Team PCMH Facilitator Specialist and a certified John Maxwell Leadership Coach. Charlotte is employed by the Illinois Critical Access Hospital Network. Susan Runyon of Kansas started her own consulting firm in 2016. She primarily assists critical access hospitals with quality improvement activities and programs along with quality data reporting. Her background includes more than 14 years in hospital risk and quality management with 29 years overall in a variety of healthcare roles. Most recently, she served as program director for the Kansas KHC. You can tell us what KHC is. She also served as a quality improvement project manager for the KFMC. Some acronyms here, I don't know, I apologize. Susan also has experience evaluating facility quality programs, leading patient and family engagement projects, teaching Lean and PDSA methodologies, and other performance and quality improvement training. Her clinical background is a paramedic, both in the field and in a rural hospital emergency department. She holds a master's of healthcare leadership from Friends University and a Bachelor of Science degree in healthcare administration from Southwestern College. And then also Krista Eiler currently serves as the Director of Nursing at Fulton Community Hospital, a 12-bed critical access hospital in Northeast Kansas. She has the honor of serving in an organization that is progressive and constantly evolving to ensure that they are providing the highest quality of care to their community. Krista has led efforts for Fulton Community Hospital to become the first and currently only hospital in Kansas to be recognized as an age-friendly health system. As a nurse of 17 years, her dream was to work in the ICU, but after living her dream, she found her heart led her to the critical access setting where she hopes to stay as long as they will tolerate her constant stream of ideas and projects. So with that, I will go ahead and open it up. Should we start with Illinois?
No, actually, Susan has the slides.
Okay.
And it's a group presentation.
Perfect.
And I'll start a little bit of this. Is that all right, Susan?
Sure.
All right. So here in Illinois, we had really been trying hard to figure out this whole swing bed thing. We have a division of our ICANN office is Survey Solutions by ICANN. We are a certified CMS approved HCAHPS vendor, and then we do a lot of other surveys, you know, all your outpatient ancillary services, as well as home health, hospice, and nursing homes, and, you know, just that plethora of surveys, you know, kind of like Press Ganey, but cheaper. So anyways, we had started looking at swing beds, and we started with one of our local hospitals saying we want a rehab survey. Great, yeah, yes. And then we wanted to try and capture some swing bed quality metrics, of which we were really struggling with in chart abstraction and going back retrospectively. So we have twofold that's going to go on in this, but I really want to, you know, just share. And I started with some conversations. I believe it actually was Jennifer Finley who we started with, and she's like, "Hey, you know, we need to look at this." And I'm like, "Yeah, let's do something." And so she hooked me up with Susan, who is going to actually do most of this presentation, because Kansas actually, you know, shockingly, our Illinois hospitals didn't want to start this yet, and Kansas did with their Flex grant, and really look at what we can do to enhance and improve the swing bed experience and capture this information. As you all know, they're not allowed to get the HCAP survey. So we have to find a way to get their feedback. And so Susan and I started chatting along with Jennifer, hooking us up. And that's where it all started. And Holton is just one of our star players. They do everything front end and say, we want to do that. We want to do that. And I'm like, yes, golden. So here we go. Susan, I'll turn it over to you from here.
Okay. So yes, definitely if I can find there we go. I had to find how to advance. So a little bit about Kansas. We have 82 critical access hospitals. So certainly have participants if we can find the right folks. And we spent some time, like Angie said, Jennifer really wanted to make sure that we were meeting the needs of these hospitals. What could we do? Sometimes, we know HCAPS is not maybe the inpatient themselves is not maybe the main player for most of these hospitals. Swing bed is. And so, some of our hospitals are getting, 6 or 7 HCAP surveys returned maybe in the whole quarter. And so what could we find the value of? But to back up just a little bit, how we kind of did this is Jennifer and I, and she's on the line, so she'll probably chat in some comments too. In fall of 2018, we really asked for volunteers. We went to a conference where long-term care and swing bed skilled folks were, and asked, we said, hey, we've got some flex funds. We'd love to find some new ideas. Who might be interested? So we had 13 Kansas Cause requests to be part of this focus group or work group. And we had our first meeting in spring of 2019. We really wanted to figure out what they needed. So why did they volunteer was a big issue. We wanted to know, what could we help them with that would help demonstrate the value of swing bed, and what could bring, what did they really want? They wanted to have some pieces for marketing. They definitely wanted to have some things that they could take back to PPS hospitals. They wanted some things to share with their community. And so we really asked them, what would show a successful swing bed program? How could we help you demonstrate that? And we decided both in patient experience and in quality measures, really, how could we do this? And so, we talked about specific things. We got out the flip charts and started to vote on things. We had Angie come on and with Survey Solutions talk about that. She even talked about the quality measures. We're going to talk about those a little bit. We had Stroudwater come on with their measures as well. We even entertained our own QHI. Here's Kansas bred and certainly available to write measures if we wanted to do some things like that. And so we really wanted to wrap our brains around what could we do quickly, because in the vein of quality improvement, we didn't want this to drag on for years while we figured out what we could possibly do. So our group chose to go with Survey Solutions. The main reasons are here. They were already surveying. They had already used this tool. We just were going to kind of be additional, but they already had some established questions, obviously. And we really appreciated the instant the ability to do the surveys upon discharge. And so, we had 11 of our participants, so 11, remember we started with 13, 11 folks of that work group decided to come with us on the venture of the patient experience. One was already doing their own surveys on swing bed with a large, the kind of the unaffordable one for most of us. And then the other folks were doing their PFAC actually decided, hey, they took this information to the PFAC and said, would you guys like us to be a part of this work group? And they wanted to develop their own survey, which certainly I find the value of even that response and that interaction too. So 11 groups, 11 hospitals, hospitals have been on this journey with us. I wanted to really paint the picture of kind of what we did so that if you want to replicate it, that's the value hopefully in this experience. We did an email invite for an informational webinar with Survey Solutions so that we could all kind of talk and figure out what happened, what will happen, how this might work. We did email a participant agreement. We wanted hospitals to And we find that very valuable here in Kansas, to make sure that they know what they're agreeing to also make sure that that leadership has to sign that. So the leadership knows the time, the commitment that's being asked of them. Survey Solutions does email a business associate agreement. So, they also had some pre-calls. I forgot to put that one on there, where Survey Solutions, reached out to all the hospitals, made sure they had what they needed. We all held an informational project webinar where Survey Solutions was on, Angie was on with ICANN. We all hospitals were on there. Even they had IT on there because we knew we were going to be using a tablet. We did have a deadline for that participant agreement. We needed to make sure that we do ask a $250 participation fee. That mainly was to cover the technology of the tablet that we were going to have to, we didn't want there to be any issues with the tablet or paying for the technology piece, but also we find that our Kansas hospitals do better, more committed if they have some skin in the game. So we do ask a participation fee for that. We emailed out the recorded webinar link if they needed to get more people in, and then of course the participant agreement went out as well. We did a kickoff webinar then about how this was going to work. I do coaching calls, a lot of hand holding, coaching calls though 1 week before the survey started. So I wanted to make sure that, okay, so we're starting 1 week from today. Who's doing the survey? How are you going to do it? What are your plans? Because sometimes we have the best laid plans, but until we get closer, we don't really have everything laid out. So the coaching calls are important. We do monthly, what we call huddle calls as well, but the monthly reports right now, Survey Solutions are sending, because we have 11 participants. Monthly graphs are created. I was doing those in-house. I will tell you that that's a heavy lift, and probably as we talk about future sustainability, not something that we're going to sustain. I'm going to tell you about that, but at this inception of this concept, that's what was happening. So I would get the reports from Survey Solutions. I would make comparative data graphs because that was something that was very important to our hospitals. It's a bit competitive too to see how you're doing compared to others in this group in Kansas. So it's kind of nice. So I was creating those comparative data graphs and getting those back out. Monthly huddle calls. So hospitals and Survey Solutions, Angie would join. We would all, be on the calls. We have them standing once a month, and we are really on for a long time. We would sort through questions or how we were going to do certain things or any struggles they were having, troubleshooting. It was nice to hear just anything. You'd be surprised what all hashes out there in the monthly huddle call. We do have someone that we don't record those calls. They are just phone in, but we do send out the notes if they're not able to attend. I think the time frame, I want to talk about this. We started doing this for, October 1st of 2019. Our goal was to do 6 months. And so, we really had plans to do 6 months, and we met in February, and we're working on a strategy to get this out to, to the state, to let them know about kind of how it had gone. And of course, February was pretty normal, seemed pretty normal, and then March was not so normal. So the challenges of COVID, we've extended, and now we're extending through the end of the year. So this pilot group, this group of 11, we just feel like the challenges of COVID right now really haven't gone away completely, obviously. That's why we're all here virtually. But we wanted to make sure that we're still gathering data. We're still having relevance. In fact, it's going to be nice to look back and see even the dip in total population. The total swing bed numbers will be interesting to see over time, I think, and how we've been able to rebuild and reestablish patients back in the facility. And then, of course, that's our strategy, to develop a statewide rollout. Probably right now we're thinking after the first of the year. Of course, obviously things can change as we move forward, but the challenges of COVID have extended this more than we thought it was going to. We thought we would start it with a 6-month time frame and then move us to a statewide rollout strategy. So Angie's going to talk now about the actual questions, and then we're going to look at some of the graphs and some of the things available to the participants on the Survey Solutions website.
So you can read the questions here in front of you. We really tried to format them similar to HCAPS, even though we can't use those same ones, but also similar to what an LTAC would use in rehab or rehab certified centers. So we really kind of played around a lot with what is very specific and can be user-friendly in various settings. I do want to point out, Jennifer did point on the chat box as well. Kansas, I tell you what, if you guys have not worked with Kansas, let me tell you, they've got it going on. Their hospitals are very innovative and looking at ways, and they will throw everything at you. I want, yes, no, can't, can, I don't like, you know, everything. They give it to you. And, you know,
I take that as a compliment, I think. So.
It is a compliment because, you know, so often we develop something and it doesn't meet the needs of what folks are looking for. And we really felt like we had to figure out what is their true need. And, you know, again, I cannot say enough about, you know, all your hospitals. It's so much fun to work with. But anyways, these are our questions. We started with some nursing and then some rehab needs, and then we'll go to the next one. And then, you know, a little bit more on goal setting. You know, a lot of our swing beds are either there for medical management or rehab. You know, so we had to look at both and, you know, look at what were those true needs identified, you know, to demonstrate, you know, the ultimate, which is quality of care. You know, what happens next? You know, that's why we do HCAP. So, you know, it's the same reason that we do the swing bed as well. And then I don't know if we have any more questions. Nope. So go back one. So as you look at these, you know, we do still have the two, 11 and 12, which are standard HCAPs essentially. Would you recommend and rate 0 to 10? Again, these are tablet, and on the tablet, and I wish I had one, you know, I should have been more Johnny on the spot. It's touch, you know, so it's very easy to answer. And the 0 to 10 is just a bar, and I think it's stars even. And
stars now.
How many stars you want.
Stars now.
Yep. It used to be something different, but now it's stars. You know, so again, we're trying to fit, you know, something very specific. And if you start looking at this, and we're going to talk further, you know, on the quality of care outcome metrics, but this really starts to build the non-financial components of swing, the value we provide to, you know, our tertiary cares and PPSs, you know, to demonstrate why they should come back to us. And it fits on one of those additional measures in and be quick. Woohoo! So, you know, we definitely have a very nice product. So, and again, we'll go into the dashboard here, but I don't know if Jennifer or, you know, Holton community wants to pipe in at all. I know Holton's going to be presenting as well, but just that infrastructure of development.
I mean, I think the beautiful part for us was we were able, like you said, we probably throw the kitchen sink at Jake. He probably loves our huddle calls. But the nice thing, beautiful thing about this project really has been a collaborative effort where we were able to give that monthly feedback and say, hey, you know, our people are struggling with this particular wording, or our people are, you know, not understanding, or, you know, we're going to talk about the tablet here. And, you know, initially we thought, wow, tablet, that's great. You know, we're going to love it. It's going to be perfect, no paper. I think we were all really excited about that. I know Jennifer and I were. And then, you know, some of our older population, which is what's in the swing bed, struggles to use the tablet. And I think you have some that are very savvy in the technology world, but some that are just apprehensive, or their dexterity is not to the point that they could use the tablet well. So some of our first huddle calls were, what do we do if they can't, you know, or if they're hitting the wrong button, or they can't read it so well, you know, or they don't understand the question. You know, ultimately you would want them to be able to answer it, you know, privately, but we just have found it isn't possible in some people. So they have been, you know, we spent some huddle call times on that. Some of them have gone to paper because they realize the person just isn't able to answer them on their own. mainly when families there, they really embrace the tablet, and the tablet's been beautiful because it's instantly entered. It's not an additional step. So I think that's probably one of the big lessons learned that we'll talk about tablet versus paper and kind of how we've developed the paper even. But the collaborative effort with Survey Solutions just being so receptive to everything, like Angie said, that we threw at them has been beautiful relationship. So
who's talking on the dashboard? Me?
I think it's you. Yeah.
Sorry. All right, so here's our dashboard. Everybody is given their login to Survey Solutions, and depending on if you have other surveys or not, you'll see a specific dashboard. This is just for those hospitals that are only doing swing bed with us. So when they log in, this is what they see immediately. And they see, would you recommend, and those top performing domains of what quality of care are they doing really well. And as you can see, this one, transition in care, staff engagement, their experience of care, and overall rating and recommendation as far as their tops. So you also see comments. If the patient were to provide a comment, if they didn't want to type it in, we do have the ability for staffing to type that in as well. But again, you get that immediate dashboard, and you can see that immediate response. And obviously red, yellow, green. And then you go into the actual domains and questions. And I know these are really tiny, but again, it just gives you an idea. So we have, our staff engaged, and then it goes through each question, but then it goes through the never, sometimes, usually, always. So you can really start to see where are my weak points, and in my opinion, we look at that, always is great, but it's that next one sometimes that we've got to get them to sway further towards the positive. So that's really what we want to look at, is that, because obviously we don't have a lot of negatives in any of our data. So it's that always, and then that usually or sometimes, just looking at that next one. So 1, 2, 3, 4 being the best, 3 is, our opportunity. And that's what we want to look at. And there's multiple ways the data can be sliced and diced. It's printer friendly and easy to copy over into any form of a board report if you wanted the board to see it. So with that, again, here's just another view, so you can look at where am I as compared to others, as compared to goal, and what does the dip look like, and how many am I doing, that N, how many swing beds did I have this month or the next month, so again, it just is just a slick way of looking at data and how we're doing overall. And again, if you see some of those ups and downs, looking at that.
I think one point I wanted to bring up, like you said, not a lot of negatives in the swing bed. So really what we ultimately have been really focused on is if they answer always, 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 always to the majority, but if there's one that they didn't answer always to, then you really think, okay, that must have had a strong impact. And so we're looking for any deviation from what they consistently were answering in all questions. And so that's been helpful too. I wanted to then just show you, this is the support that we provide here for our project, how it's structured for us. It works really well. This is just the look of what we have going on here in Kansas. If you want to mirror, I want to talk about the project successes and then turn it over to Krista, who we're honored to have a hospital to be able to join us and talk about their experiences in it. The beautiful part for us, the immediate patient experience information, having it available not 6 weeks from now, that timely improvement opportunities, being able to really drill down immediately and say, okay, whoa, we've had 3 patients who've talked about activities not meeting their needs, so we have an issue, but they answered always to everything else. So really being able to assess the patient needs, allowing for that immediate program modification or staff education as needed. So really the true quality improvement, the beauty of it being timely and really relevant, making sure, like you said, a rural relevant population that's larger, I said earlier, than our acute care admissions in our hospitals. And so this really is a great value for the cause. Some of them don't find the value in an HCAP survey because, like I said, some of them get 6 1/4. I have one hospital who doesn't get any in a quarter, and several quarters in a row, maybe have one in a 9-month period returned. And it's not because it's just their population so low. Maybe they only had 9 in the whole 9 months. So it's a low census for inpatients in a few of our hospitals. Pricing is very reasonable, very manageable for smaller organizations. In fact, that one that I told you was not participating because they were already surveying their swing beds, patient experience. She looked at the pricing that we were, going to be discussing with our Kansas hospitals, and she was like, "Well, if our CEO could see this now." So, definitely something that that is rural friendly. An interesting component, we have the 97% response rate. I think that's probably even higher now. Early on, we struggled and did some tablet kind of, not modifications, but really encouraged our staff, the staff there at those hospitals, to start using paper if they were struggling with some. So I imagine our 67% response rate is actually pretty low compared to what it is now. But overall, 67% response rate. So, Krista's gonna unmute and talk a bit. This is about, I'll let you explain it, Krista. I'll be quiet. So thank you for joining us here, Krista.
I'm excited to be here and talk about why, as a hospital, it was important for us to engage in this work. As a critical access hospital, I think we are not alone in that we have very limited resources. So as we're looking at projects, there's lots that we want to take on, but we have to be really careful that we're choosing projects that offer value to our organization, to our patients. And this is one that immediately we knew we wanted to sign on with. This just made sense. We have a lot of swing bed patients. That's our primary population. So we were doing an internal swing bed patient satisfaction survey, and those questions, you'll see those on this slide and the next slide. These were questions we developed on our own. We didn't have a great response rate. It was a paper survey, so we handed this to patients at discharge with a self-addressed return envelope and asked them to mail that back. We did not get many back, so that was disappointing, but we weren't really using this for anything. We reviewed it every month diligently in a couple different committees and did nothing else with it. So this really was not offering us anything of value. So by participating, we gained a lot and are very excited about the direction we're headed. So the comparative data was huge. I think Susan hit on this, but certainly we're not alone in that our staff are perhaps a little bit competitive. So seeing that how Holton was doing, but how other Kansas hospitals were doing, other critical access hospitals with their swing bed patients, was a really big driver for our staff, and they really valued seeing that data. Our swing bed coordinators actually took that and set performance goals based on that feedback. They had 2 areas that they thought, we're not okay with how we're scoring here. One of those was activities, and they made that a goal for their performance for the year. We shared the results throughout the organization, but one of the nicest things for me to see was for our therapy department and see how excited they were to get feedback that was relevant to them. So I think they often feel overlooked within HCAPS, ED caps, there's nothing therapy related. They really weren't getting any direct patient feedback on the service that they're providing. And for our swing bed patients, most often they're getting therapy. So they really valued that feedback on their service, and it was nice to see that. Obviously, most importantly, our patients. I know that we provide outstanding patient care. I think critical access hospitals across the nation do. It's a really special environment. We have really special relationships with our patients. They just get outstanding care, and we know that, and we hear that from our patients. But really resonated with me is we're not illustrating that in any way, shape, or form. There's no way to paint that picture outside of our own hospitals, and that's really important moving forward. Organizationally, I will say the commitment from the organization was very important. We have a CEO that recognized that, yes, we're investing in something that doesn't have a direct return, or direct revenue return, but recognize the importance of that feedback from our patients to ensure that we're providing the quality of care that we expect. But most importantly and most interestingly, it was our CFO. And our swing bed coordinators, we are very near an urban area. We're near Topeka. And we have a very high population of Medicare Advantage plans in our area, higher than most in Kansas. And as we see that increasing each year, I would say 30% of our patients at this point have an Advantage plan. We're getting a lot of questions from those Advantage plans about the cost of the service we provide and what's the value. They're really looking just at the bottom line and saying, the cost is higher in a CAW, and they could go to a long-term care facility and get the same service, and it's not the same service. So we need to start demonstrating that and illustrating that. I think I had paper versus tablet, but Susan kind of hit on that, and I think she's going to hit on it again in a minute, so I will leave that to her. I will just say it was very exciting for us to kind of be a part of determining what we want to measure, how we want to measure it, and what is meaningful to us as an organization, but as a state as well before it's mandated, because I expect at some point this is going to come down the pike and we're going to be asked to provide this. Yeah. Back to you, Susan.
Perfect. Thank you. So I think some takeaways quickly before we move into kind of just a little bit of touch on quality measures as a whole, but really lessons learned. If you're going to replicate or work on this or think about working on this in your state, the monthly huddle calls have been huge, something that we plan to continue even as we move into some quality measures. We picked some quality measures to work on. I'm kind of really excited about that just last week. So I'm excited. Tablets versus paper, we had a lot of excitement about the tablets, then we had some frustrations, and so honestly we did paper. We encouraged our people, if your patient is struggling with the tablet, just hand them the paper, or let them, we have some that are letting them read the paper and then they're putting it in the tablet right in front of them. So it's a modified ways, but great to get the information out. We did do some population definitions, because when you're looking at a return rate, you don't want to include people who passed away. You don't want to include, was that considered a dismissal? So we really worked on some population definitions for our group. And then the other most recent thing we developed was a Spanish language paper version, and just Vietnamese was the other one just last week that somebody requested. And so very valuable. We shared that back with Survey Solutions, and they're certainly able to share that with other hospitals that are doing it, because if you're going to hand out the paper version, you certainly need it to be language appropriate. So Angie, I'm going to turn it over to you for the quality metrics conversation before we open it up, I think, for questions next.
All right. So before I talk a little bit on quality metrics, I do want to share, we also, I think on the swing bed, I know we have it on some of our other tablet version surveys in other areas, that did a staff member help you in answering this question? I don't think we put that on our questions, but we really wanted to make sure that no staff influenced or were present while they answered the questions. Because, when you're collecting real-time data, people are going to feel pressured to answer, very positively if staff were watching or answering for them. And those were some of those things that we wanted to look at, as we continue to move this forward. I also want to share that Kansas is going to have a run for their money. We have 21 hospitals in Illinois starting the swing bed pilot I was going to say next month in August, but it is August. Nice. And Laura Fisher, who is our Flex coordinator, God love her, she placed it into the Flex grant because I twisted her arm enough to say yes. But again, to get some hospitals engaged with this. So, if there's other states that would like to do this, please, please, please reach out. It really is a very worthwhile, I think, movement. The other piece is quality, so we're getting patient feedback now. So really, what is their outcome? And going kind of into Nick's question, when you start thinking about is, swing bed pricing comparable if you consider lower cost of readmissions, the penalties that are associated, lower length of stay and decreased infections? Absolutely. But we also look at the outcomes. They didn't have to go to an extended SNF. They got to go home with or without home health. We gave them the things that they needed, so that we can demonstrate those outcomes when you start to market out to the masses. So some things we're looking at. And again, we tried to capture this early on SurveyMonkey. And hang on just a minute, I have a spider climbing up my wall.
Oh, okay.
That was gross. So here I am in the office. So anyways, we have length of stay. You know, what is our true length of stay? And then, you know, before when we were looking at this, it was length of stay. How many times did they go back into inpatient setting versus staying in swing? We took all that out. And then we look at diagnosis. What are our top diagnoses? Is it medical or rehab driven? You know, and we use Carrie Dunning. She is our subject matter expert for our swing bed platform. And we started looking at what are they finding in swing bed surveys as far as CMS, you know, validation surveys or your state surveys. So we started looking at those nursing skill notes. We found we were having a lot of our hospitals failing to really utilize the EMR effectively to have that nursing skilled note every 24 hours. Activities, you know, now that we don't have to have an activity coordinator, you know, a true activities person has to be in the care plan, still nursing driven. We need to have something. So we're going to look at that. And then our therapy evals, they're completed timely. They've met short-term goals. We're using a standardized functional assessment tool. We found we were having multiple different kinds of functional assessment tools out there. Some were even homegrown, you know, and looking at what can we do a little bit differently. And then did their functional status improve prior to discharge? You know, quality of care. What did we meet with them, you know, to look at this? And, you know, when we start to look at, okay, do we want to do retrospective quality measures or do we want to capture real time? And I really think there's a good way to do this right in the platform. And we can, you know, enhance it by then having all those quality metrics right in our dashboard. So when you log in, you get what they recommend, what is our quality of care outcome, and what's our quality metrics. Hey, look at that. We are good, we are bad, we, you know, we suck, we're great. I don't know, you know, so, you know, it's, you know, going to be a learning progress, but at least it's real time. And, you know, I really think that will enhance nursing and rehab's delivery and ensuring that those EMRs are capturing everything we need them to be successful in our swing bed programs. So hopefully I'm answering those questions a little bit. Going back to Nick and really thinking about, you know, pricing and the cost comparisons. We did a lot of evaluation with our swing bed versus SNF in our long-term care. With our ACO line of business. We have a rural ACO here in Illinois as well that we manage. And we looked at it, length of stay. Yes, does it look a little costly? Yeah, you know, but when you really put it out there, it is much more quality of care driven and patient driven. So yes.
So Nicole, I have not been reading the chat. So do you need to facilitate questions or do I need to go back and read them?
No, I'll facilitate questions. I think Angie's been mostly catching them.
Okay.
Yep. There was one question though, actually, from Stacy Rothwell about the project being included in the Flex program work area. So I don't know if Laura is here and wants to answer this, or if
yeah.
Did you see it, Laura, or if Angie, was the project included under your Flex program activity?
It was one of our innovation models in that section 5, I believe.
Okay.
Laura, do you remember, or is it in section 3 under quality?
Ours is not. Ours is in our normal quality area, and we also had another project that focuses on HCAPs. So we didn't use this solely to satisfy that requirement.
That was Jennifer in Kansas.
And I don't know if Laura's unmuted to talk.
She just chatted. She says it's in 1.3.
Okay.
That's all the questions I saw. I saw Sarah Young mentioned that there was some interesting data analysis presented at last year's NRHA conference about the compared total cost of an episode of care. So maybe Sarah, you could send that, if you can find it, a presentation or the analysis itself, if it was published, to me and or Nick, if you still know how to contact Nick from your time in Flex. Any other questions anybody has? We have Still just a couple minutes if anybody has questions. Feel free to unmute your microphone.
I do know we have just a few minutes, and I do want to talk to the Flex state coordinators real quick. Unfortunately, well, not unfortunately, I'm moving on, but I am leaving ICANN at the end of this month, and this really has been a baby of mine. And I know Laura is not showing her face, but she would much rather shoot me. She will be on.
Yes, I would.
And I'm sure I'm still going to be getting a lot of text messages moving forward. So at the end of the month, I'm transitioning out. But for all of you that have those low volume HCAHPS numbers, and this is something I'm going to throw also, Nicole, for you guys to think about. You know, we've got to help these hospitals. They have SHIP funds. They can't access them if they're not doing HCAHPS. They find no value in HCAHPS because, you know, we are an HCAHPS vendor, and we have one hospital, I think it's Arizona, maybe 5 patients in a quarter at the most that were eligible because of observation. You know, let's move this same platform into an observation status, patient satisfaction, capture it that way, but then also let's look at ways to help our hospitals to do HCAHPS themselves, because the volume is just pathetically low in a lot of our rural hospitals, and enhance what's meaningful and what really drives our critical access hospitals. That's just my, you know, my BHAG, my big, hairy, audacious goals, you know, is where I want to see this go. And I would love to see you guys take that further. And this was the only way I could talk to you and say, hey, you know, do something.
We will take that into consideration. Anybody else have any questions for these speakers or thoughts?
It's really been beneficial for our 13, and like I said, just last week we met and came up with what our next step is and the quality measures that we want to start gathering, and then taking steps, because obviously patient experience is one piece of the puzzle that our people want to be able to present and to be able to talk about the value, and then certainly those quality measures are necessary too. We're you know, we're taking the first step just because sometimes it's easier to just take the step and get going. And so we've picked 4 that we want to start gathering. We're going to just do it pretty rudimentary on a spreadsheet for right now, and get going, and then build. Then worry about the repository for us at this point in time. So yeah,
and Susan, we'll hopefully be able to add some of those into the survey platform so you can capture them.